So one relatively important aspect of physical examination I want to discuss is the concept of hypothesis-driven physical examination. So basically what that is um, you really want to answer the question is which physical examination findings will help you make the right diagnosis. So for example, if you have a patient coming to you, inpatient, outpatient setting, who's elderly, maybe a smoker, and has coming in with chronic intermittent shortness of breath and cough. As you take in history from the patient, then you kind of develop the differential diagnosis, right? And generally, this complaint has a lot of differential diagnosis in mind. But overall, you're probably gonna after you're done with history, you're gonna start your physical examination by general exam, and then you focus on the respiratory system, and then maybe on the cardiovascular system, and then maybe on the neurological system if you still think that his shortness of breath and cough could be from extrinsic lung disease from neuromuscular junction problems, for example. So your physical examination is really, you're doing the physical examination based on the differential diagnosis and possibilities or the hypotheses that you came up with after you had the encounter with the patient and took hopefully a good history. So this is a really very useful concept, and I really encourage you to think about physical examination all the time in that perspective. It could be also kind of helping with the time management if you're running out of time. So before going to the patient room, you'll have like an idea what to look for. Okay, so keep in mind that to be able to do a good hypothesis-driven physical exam, you have to know the difference between, for example, precordial examination versus cardiovascular examination, right? So precordial examination, this is basically inspection, percussion, palpation, and auscultation of the precordium, versus a cardiovascular exam is also has many components, including general exam, looking at the breathing effort, examining the pulse, examining the blood pressure in both arms, examining the JVT, looking for basic cavitation, looking for lower extremity edema, etc., etc. So cardiovascular exam basically meaning they're trying to elicit physical examination findings related to the cardiovascular complaint that a patient is having or the cardiovascular problem that you think your patient is having. And the same for lung examination, which also has the classical 4 components: inspection, percussion, palpation, and auscultation, versus the respiratory system, which also involves counting the respiratory rate, observing the breathing pattern, looking for supraclavicular lymph nodes, axillary lymph nodes, looking for cyanosis, pallor, and examining the hands, as we're gonna see in the next example. Also with neurological exam, you need to know when you need to do a little bit more detailed neurological examination versus a kind of a screening neurological examination is if you're not really expecting a neurological problem in your patient. And you always have to keep in mind the 7 components: the higher brain functions, the cranial nerves, motor system, reflexes, sensor system, coordination, and gait, and pick up whatever you think is appropriate that can help you again answer the question, what are the findings that can help me make the diagnosis. So let's take this example of a patient coming in with, again, chronic shortness of breath, and this is a CT scan, and you're suspecting that the patient is having interstitial lung disease and fibrosis. So there's no, the patient doesn't have like a known diagnosis that could be causing this CT finding. So you're trying to, from history and exam, you're trying to find what could be the underlying cause of his interstitial lung disease. So one of the things that, for example, you can look at is hand examination. So for example, if you have this patient with this hand findings, then you're suspecting certain diagnosis, which obviously is rheumatoid arthritis, whether that is early, see the puffiness of the hand, or you start to see some of the swellings in the metacarpophalangeal joint, and the deformities, Swan gas deformities, and Botnian deformities, and then the more severe advanced disease. So even before, even if the patient is not known to have rheumatoid arthritis, then maybe you can get some idea, based on the hand examination. Versus, for example, if the patient's hand look like something like this, a little bit shiny, you need some ulcers, especially where there's bony prominences. Examine the nails, maybe some telangiectasias, and in this case, for example, you're suspecting scleroderma, the underlying cause of the fibrosis, even if the patient is not labeled as such before. Or versus the patient is having these findings, which look like dermatomyositis, right, quadrant spots, or the mechanic's hand, and that might suggest also dermatomyositis as a cause of his underlying lung fibrosis. So this is really the idea of hypothesis-driven physical exams, basically looking for specific signs that could be really telling you what could be the underlying cause of his disease. So finally, general advice that I will give you, things to keep in mind related to physical exam is try to learn evidence-based physical examination, and I will give you some examples shortly, resources to look at. But try to always to think about what physical finding you're looking at. Are they really helpful? What are their likelihood ratios? If I find this sign, is it really specific for the diagnosis I'm looking at, or there's other possibilities, or how useful in general these findings could be? So keep that in mind and try to learn physical exam from perspective of evidence-based medicine again. Use a hypothesis-driven physical examination, and always try to think about the differential diagnoses while you're doing the examination, and be specific in what you're looking at and why. Be systematic, have your own approach. For example, for me personally, I like to, to start with the hand, looking at the nails, and look at the palm, and then maybe examine the pulse, and then go up to look at the rest of the arms, and then look at the neck, and then look at the face and mouth, and examine supraclavicular areas, and then go to the system that I think is mostly involved. Or you can start with the other systems and then focus on the system that you want to examine closely at the end. So always try to be systematic. Try to develop your own approach so that you know that you will not forget part of the examination. A lot of times I found that students and residents might forget even to look at the legs, just because the patient is really having all these blankets on top of them. So if you think that this happened to you a couple of times, maybe you want to start instead of starting from the hand like I do, start from the legs. Examine the legs first and then go up. So regardless, you have just do whatever you think that you can remember easily. And then be a good observer. Really, observation is really crucial in physical exam, and I really can't emphasize that more. I think a lot of times, just medical student and resident, they missed simple observations, simple sign that they really haven't looked at. Unfortunately, they haven't undressed the patient probably to look for some skin findings or deformities or scars. I have almost a patient who had bacteremia, almost missing a midport, a central line, because the patient had a very remote history of malignancy, and he wasn't getting any chemotherapy for years and years, but he still had the midport in, unfortunately, and the patient developed bacteremia, and the first day or two, until we examined the patient properly, that midport was almost missed. Also, I had a patient who I was told he's ready to go for discharge, but I found the patient on a nasal cannula, and we stopped the oxygen supplementation, and the patient desaturated really quickly. He became hypoxic, and his oxygen saturation went down within a minute or two. So obviously he wasn't ready for discharge. So things like this happen, and during residency, this is a time of learning this stuff. But this is really very simple findings. I try to look for them. If the patient wasn't from the ICU, downgraded from the ICU, maybe they have unnecessary central lines, Foley catheters in. Sometimes the this might be missed as well. So be a good observer, just looking around the patient, at the bedside, the tables, try to find some gestures from the behavior of the patient that can help you, make your diagnosis. And this is some of the resources. So JAMA has really very nice series of the called the Rational Clinical Examination. They have very nice articles tackling many important topics related to physical exam, and they're focusing on evidence-based physical examination as well. McGee really has a very nice book about evidence-based physical diagnosis, very useful, and also Physical Diagnosis Secrets. It also has a very it's written in a very nice way, and also has a lot of tips related to evidence-based physical examination. So this is all what I have. I hope you really found it useful, and I'll see you in the next video. Thank you very much. Bye bye.